Thank you all for attending our PharmCAT Family Chat with presenter Bill Jones. PharmCAT Chat is a program that we started this year. This is our second presentation, and it's really to engage our alumni and share with our current students. There's a myriad of ways that you can use your pharmacy degree. And so we've asked alumni who have various career paths using their pharmacy degree to share their experience with students, to give you an idea of some maybe other areas that maybe you hadn't thought of that you can go. The other use for this chat is that for you to be able to network with our alumni and ask them, other questions that maybe you might, haven't thought of now that you'll think of later, to maybe be interested in the career path that our alumnus has gone. So if you have any questions, please send them in the chat to myself, Erica Grasset. And I apologize, I forgot to introduce myself. I am the Director of Development for the College of Pharmacy, and we'll be happy to then, after Mr. Jones is finished with his presentation, to ask him questions. If you can, all little housekeeping, put your monitors on mute, that would be wonderful. And I am going to introduce our speaker for today. Bill Jones received his Bachelor and Master's of Science degrees from the University of Arizona College of Pharmacy in 1972 and 1979. As a student, he was the SAPHA president. He spent 4 years in the U.S. Public Health Service. After his master's degree, he was the pharmacy program manager for clinical services at the Southern Arizona VA healthcare system for 29 years and was a residency program director from 1983 to 2006. He also was the education, research, and performance improvement pharmacist for the VA Central Office for 3 additional years. Bill retired from the VA in September 2009 after more than 35 years of federal service. He's an author of more than 40 peer-reviewed articles and book chapters. He's quite an accomplished career, so I'm going to share just a little bit more about Bill. He is a clinical associate professor of pharmacy practice and science here at the U of A College of Pharmacy. He was a member of the faculty when the PharmD program at the U of A was developed and implemented. He is an instructor in the Department of Clinical Pharmacology in the College of Medicine since 2006. He is the clinical pharmacist part-time for the Arizona Center on Aging, Banner Medical Group, and the Healthy Together Care Partnership, a program to provide care for Medicaid and Medicaid patients. Bill was the first VA pharmacist to receive the VA Administers Hands and Heart Award and the APHA Distinguished Federal Pharmacist Award in 2006. He has been a Pharmacist of the Year twice in Arizona, in 1984 and 92, received the U of A College of Pharmacy Clinical Educator of the Year Award in 1991, Preceptor of the Year Award in 2002, and he received a U of A Professional Achievement Award in 2006. Mr. Jones has been a member of the APHA and ASHP for 48 years and is a fellow of ASHP. He is a past president of the Arizona Society of Hospital Pharmacists. Wow. And welcome. I can't wait to hear about you. You're quite accomplished. So
well, all that means is I'm old. And you stick around long enough, So, well, thank you. Erica gave me some questions to try to address, and we can chit chat about different and sundry things. To give you a little background about me, I grew up in Tucson. My parents moved here when I was 5 from Connecticut, and my younger brother had a lot of bronchitis, and so they were told go someplace dry. So they literally put us in the car and drove us here, and that was it. I mean, we had no idea what Tucson was going to be. And so I grew up here. I went to Palo Verde High School and graduated in 1967, and then applied to the university and got accepted here. One of the questions was did I always know I wanted to be a pharmacist? And I would say not always, but I can remember telling people that I wanted to be a pharmacist when I was about 15 years old. I cannot tell you why. And the only thing that comes back to me is that in my day, there were lots of independent pharmacies. And at the close by strip mall, there was a Rexall drugstore, and there were a couple old guys in there that were the pharmacists. And Mr. Silverberg was a guy, as a little kid, he used to chase us out of the store if we were reading comic books or something, but it always impressed me how he talked to people. And I think that probably is the biggest draw. Probably the other draw is Carl Trinka. Carl went to Palo Verde High School also. He's a couple of years ahead of me. And his brother and I were in classes together. So I knew Carl a little bit. And Carl went to pharmacy school, and Carl was always the cool guy. And I thought, maybe that's kind of a cool thing to do also. So probably those two reasons pushed me in that direction. What I want to also say is, as you talk about things, is nobody gets here by themselves. And there are a lot of people that participated along the way, and people that younger folks don't even hear about anymore. Willis Brewer was the dean when I was a pharmacy student, had been the dean for years before and many years after. And then Dr. Piccioni was the interim dean. He's a saint of a man. Jack Cole, who was the dean for quite a long time, when I'll talk a little bit about him, and he did a lot that most people don't know about, and I'll get into that a little bit. And then Lyle Bootman, Lincoln Chen, lots of faculty, George Wood, Dr. Zapataki. George Wood gave me the advice to go to graduate school, go to work, and find the person you want to work with. And that's a great piece of advice. Is it's more important to work for people that support you than it is to work for people that have a big name on the building, because if they don't support you, it becomes pretty long days. And I've always thought about that. And then probably the biggest U of A hero that I have is Henry W. Winship III. Dr. Winship tragically died young. He had ALS. And he was hired to be the pharmacy director at the University Hospital and a faculty member in College of Pharmacy and Pharmacy Administration. But he never was the hospital pharmacy director because he had ALS. But he was an amazing mentor, an amazing teacher. And I spent many hours sitting just talking to him as a student. Paul Consro is another one that I spent many hours just talking to about stuff, not just necessarily about pharmacology. So there are a lot of folks there that are there. When I was a student, it's kind of funny. Dr. Simonian, when we had a class called pharmacognosy that you guys don't ever have any clue what it's about. But we used to call it weeds and seeds. And Dr. Simonian used to say, when I was a boy in the pharmacy. And so now I can say when I was a boy in the pharmacy. But the College of Pharmacy program then was 5 years long. It wasn't terribly long that earlier that it had gone from 4 years to 5 years. And we had a 1 year pre-pharmacy program and then 4 years of being in the College of Pharmacy. And unlike today, it was kind of a seamless endeavor. You applied, you got into pre-pharmacy. If you didn't either drop out or fail, then you kept moving along with your class. The College of Pharmacy, when I attended, was a shared building with microbiology on the main campus near 6th Street. If you know where the physics building is, the building right behind it, I think it's veterinary medicine now or something like that. We had less than half the building because there was one floor that was blocked that was all microbiology, because I think they had a bunch of lab space up there that, you know, with things growing that they probably didn't want people mucking around with. I was an intern for Old Pueblo Drugs. Doesn't exist anymore. Old Pueblo Drugs was at Broadway and Campbell. I worked for a man named Herb Michelle, who was a U of A alum, graduated in '61, and he treated me really well. You know, I told him that I really wanted to do well in school, and his expectation for an intern was to work essentially 40 hours a week. And you know, I said, I can't do that. And so he actually allowed me to go find other students, and we would split up the time to be an intern. And then fortunately for me, on Sundays, particularly Hugh Laird, who was also a U of A grad and at the time was a PhD candidate, did work with me on Sundays. Usually meant that Hugh read magazines and I did the work. But what Hugh did was he taught me physiology, and I'm forever grateful to him to have spent that time with me. But he is a great guy, and he ended up on the faculty here for many years. He ended up leaving and going to a new school. I want to say it was Texas Tech is where he went, and also tragically he died of ALS at a fairly young age, and it really is sad to have seen that. So one of the questions was about how my career path formed. What I can tell you is after being an intern in a retail pharmacy for 4 years, I never wanted to do that. And because it was business and I wasn't interested particularly in business. And Herb used to tell me that. I mean, he used to say, oh, you know, don't worry about it, just run the business. And as much as I loved Herb, you know, I just couldn't do that for a period of time. So I actually applied to medical school and didn't get accepted, which was a fork in the road that probably turned out to be a good thing for me and maybe for patients, because it didn't happen. And I applied to a handful of places, and I interviewed at the U of A, and you know, I'll remember one of the people I interviewed with, who still is around, is a physiologist and a surgeon, and her research was on regeneration of salamanders' limbs and how that happened and why it happened. And she asked me what I didn't like about college, and it was physiology, because the guy that I had didn't teach us anything about mammalian physiology, and probably the wrong thing to have said to the person interviewing me, but oh well. Mentioned that I was the student APHA president. I think I won by 1 vote in that election, and we attended the regional conference. It was at the University of the Pacific in Stockton, and they had sent us a ton of stuff to read, and I actually read it. And somebody was asking a question, and it was some policy related sort of thing, and raised my hand, and I said, well, it's this, this, and this, and The guy said, oh yeah, you're right. And then later on, as the people from out of California were having an event, this guy came up to me and asked me if I'd ever thought about working in association management. I said, no, I never thought about it. And he said, well, I was really impressed that you knew this, and I said, okay, fine. And I came back and sat with Winship, and I said, this guy's talking to me about this stuff, and he said, who was it? And I said, well, his name's Bob Johnson. He said, do you know who Bob Johnson is? I said, no. And he said, well, Bob Johnson's a really big deal. I mean, he is the executive director of the California Pharmacists Association. He was director of the Michigan Pharmacists Association. He was president of APHA. And I said, wow. And we used to have a breakfast, Lyman's Day breakfast. And I invited Johnson to come down and talk. And he took me to dinner and, wined me and dined me and tried to impress me. And, as a young kid, I was really impressed. I was, oh, that's pretty cool. And I went to the APHA meeting, was in Houston, and Johnson got me a meeting with the Bill Apple, who was the executive director of APHA. So I was up in his hotel suite having breakfast, and he says, well, Johnson tells me you're this great thing, So as a kid, you're really, ooh, this is pretty cool. And, but it quickly became apparent that I couldn't work with people that did business. I mean, that was what pharmacy was. It wasn't, I really agonized over it. I didn't know what I wanted to do. I could tell you what I didn't want to do. And then one of my classmates, Dave Morgan, he said he was applying to a pharmacy residency program in the public health service. And at the time, I'd never heard of a pharmacy residency. So I quickly got the packet together and mailed it in, and I wasn't picked. But I got a phone call from Alan Brands, and Alan Brands is actually a big name guy that you probably don't know if you're not my age. And he asked me if I would be interested in being a pharmacist in the public health service, not a resident, and that I would be assigned to a hospital in Norfolk, Virginia, and which is also now closed. There's a theme to where I've worked. It's most of these places are now closed. So I went to Norfolk, Virginia with no idea. Dr. Burton told me it was a place where signs that said, sailors and dogs, please stay off the grass. And I thought, well, man, what I learned very quickly is I hate humidity. And it was like being underwater almost all the time. And I kept thinking about, I wanted to go back west, and I would talk to them about going to the Indian Health Service. And they said, well, you're going to start at the bottom of the ladder. And I thought, how can that be possible? If I had 2 years in, how can I be below somebody that's just coming into the public health service? And so I just stayed. And then my boss, his name was Al Falavalita. He kept telling me to go back to school. He said, you need to do this. And I had a lot of physicians. A really great aspect of the public health service at the time was this is a uniform service, and there were a lot of physicians who went into the public health service so they didn't get drafted and go to Vietnam. And so I worked with an incredible group of physicians, and most of us were similar age. So we all became friends. We all wore exactly the same uniform, so there wasn't any of the one-upsmanship of, whatever. And so I learned a lot about taking care of patients from them. I learned a lot about pharmacy from Al Falavalita. I think Al is probably the best pharmacist I've ever worked with. And he knew pharmacy stuff, and he knew clinical stuff, and he was a great asset to my learning about stuff. So back in those days, there were very, very few PharmD programs. Most of the programs were master's programs with or without a residency. And, I talked to a few PharmD programs. I found the faculty there to be very arrogant. And I thought, I can't do that. I got accepted to the Medical College Virginia program, and without an interview. So I went up to interview with them, and I met with one guy that I just couldn't see working with for the 2 years, because he just he made rigid look like it wasn't rigid. I mean, it was really tough. And every time I would talk to somebody, I would call Carl Trinka, because Carl Trinka was the head of pharmacy practice. And I said, who do you know at this place? And Carl would say, well, I know so-and-so, you know, and they're pretty good, and they're doing this and they're doing that. But then he would say, come back here. And if you listen to Janice last month, she mentioned that the College of Pharmacy had accreditation difficulty. And this was at a time where I was out of town. So I actually learned this history later on. But the College of Pharmacy's accreditation was very threatened, because they had really no clinical program whatsoever. So Jack Cole pulled together the 3 deans from the California pharmacy schools that all had PharmD programs, Jerry Goyen and Dean Biles, and I can't remember the third guy off the top of my head. And they came in, did a review. They said, you need more clinical people. Dr. Cole went over to the medical school, got Ruben Bressler, who was a clinical pharmacologist, to support him. They actually got funding with the Boston Collaborative Drug Surveillance Program that hired Carl Trinka. So Carl was the first person wandering in the halls, the wards at the university. And Dr. Bressler, who was an interesting character, to say the least, loved him. And, you know, that boded well. John Palmer, who's a PhD, MD, clinical pharmacologist that I spent a lot of time working with, was also very supportive. And so everything was greased. They had a public health service manpower grant. I've talked to Carl. Carl said, they handed it to me. They said, sign here. He said, I didn't do anything to it. It was all done, mailed it in, and then they expanded. They got a bunch of new clinical faculty. So Alan Baruther, who is an alum, was one of those people. Bob Dorr, who's an alum, is one of those people. Vic Ellsbury is an alum, one of those people. But they also hired some other folks. They hired Bob Powell, who's a really smart guy. John Plachetka is a really smart guy. Marie and Lee Gardner, Tony Silvani. So they had this big group of people that didn't exist when I was an undergrad. So I finally said, okay, I'll come back and I'll do this. And I told them I wanted to do clinical things, and the master's program was really hospital pharmacy. And they said, well, take the core classes, and then you have 15 units to do whatever you want. And so I got to go and do rotations. I went to the Phoenix VA, and the college pharmacy actually paid me to go do a rotation because they wanted to find out about Jim Guidry at the Phoenix VA, who was amazing. He was a really, really great guy to work with. They also, in that grant, hired Mike Mayerson, who recently retired, and Don Perrier, who became my major advisor in graduate school. And they taught pharmacokinetics. And back in my day, there were lots of drugs where we did lots of pharmacokinetics and therapeutic drug monitoring, which today don't get done. So it was a very different college of pharmacy. Now, there were some people. Dr. Piccioni was still there. Dr. Chen was still there. Dr. Cole was the dean. Dr. Cole gave me an assistantship so I could make a couple of dollars. And so I got to know some of the faculty because I was a grader more than anything else for some folks. I did rotations at the university. It didn't fit well with me. I did rotations at Tucson General Hospital, which is now the Cancer Center. I spent a month at the Phoenix VA in a very hot summer. So I got up really early in the morning, got to the hospital so I could stay inside where it was air conditioned, and stayed until really late because it was air conditioned. and learned from Jim Guidry and did a lot of stuff. And it was a good time. And I did a research thesis project with Don Perrier and Carl Trinka and some other folks. And most of the data that I collected was at the VA in Tucson, and I did a rotation there. And most of my data collection was really early in the morning, so I could spend the whole day doing whatever I wanted to do. And so I got to know the folks there, and they were great. They were great. I mean, there were a lot of folks that supported me, and the Dave Hager was the chief of cardiology, and I did stuff with digoxin kinetics, which, anybody except, I see Lipsy's name on there. So Lipsy knows about digoxin. Nancy probably is a little too young to know about it, but I'd go to Hager, and Hager would get the cardiology fellows and the residents together and say, let's find everybody on digoxin today that was, a cardiology patient. So I could go talk to them and see if they wanted to be in my study. And Hager was a prince. There is no question about it. And I learned a lot about the VA style, and I liked it a lot. And but they have one guy there. His name's Bill Fritz, and Bill Fritz didn't look like he was going to leave, and then he did. And he left in a perfect timing sense to when I was finishing. And Carl called me up and said, "Do you want to go to the VA?" And I said, "You betcha." And so in 1978, November 1978, I started working at the Tucson VA as the only clinical pharmacist. I was the only person that ever stepped outside the pharmacy, to be honest about it. And so I was there 6-7 days a week, 10, 12 hours a day, trying to do what I thought needed to be done. And in 1979, Carl and the rest of the faculty said, "We're going to get you a faculty appointment because we think that the VA is a prime place for us to send students. We want you to be part of this." And so I was a clinical assistant professor, and then John Murphy wanted me to be promoted to a clinical associate professor. And so I've taught every class of pharmacy students from graduate school till now is a little over 40 years. But as a faculty member, I taught every class of pharmacy students for 40 years, and had hundreds of students do rotations, had lots of students do case discussions. And it was interesting when Dean Schnellman came to the U of A, we went to the mid-year meeting and hanging around by the reception, and lots of people would come up and say, "It's great to see you," and give me a hug or shake my hand. And he looked at me and goes, you know some people, don't you? And I said, "Well, it happens when you're hanging around for 40 years is you know some people." And so those connections, I think, still make a difference. At the VA, I was extraordinarily fortunate to work for Bill Fisher, the guy that was the pharmacy chief, was close to retiring. You could tell he was close to retiring when I went to work for him. And then he retired, and Bill Fisher was a fairly young guy, came in, spent a lot of time looking around. His idea of a clinical coordinator was an administrator. I told him that was a mistake. And he said, "I don't care. I'm the boss. Do it my way." And I just ignored him, which is pretty typical of what I did a lot of stuff doing. But he came to me about 2 months later, and he said, "They hate the pharmacy, but they love you. What are you doing?" And I said, "I'm trying to help them take care of their patients." He goes, "Well, let's go back to that." And that's the kind of thing that I mean when I say you got to find the people that are going to support you wherever you work. Because if you don't find that person, I don't think it's a very fun time, to be honest about it. And work is a 4-letter word, fun is a 3-letter word, and we ought to focus more on fun than 4-letter words. But we were really innovative. Bill Fisher was a really bright guy, saw many opportunities. We were the first hospital in Tucson to decentralize pharmacists. We got unit dose drug distribution funding, and he wanted to decentralize the pharmacist. instead of having unit dose drug distribution done inside the pharmacy, we did it on the wards. And he made sure that people were visible and potentially, quote, vulnerable because they might be asked something. So that expanded the basis, I think, of our clinical program. I had great other folks that I worked with, Tom Stavanger, Frank Yunker. When we expanded, we were able to hire Joe Rondoni, who I still call the Oracle. Guy knows everything about everything. He's an amazing clinical practitioner who's now retired at the Prescott VA and runs a heart failure clinic that's amazingly successful. Wendy Monroe, we hired. Joe McElroy. Suzanne Campbell was actually hired by the College of Pharmacy to work at the VA because we actually did about 2 full-time equivalent workloads of faculty for 0 support. And so, Dr. Cole and I had that conversation. He said, well, you ought to split fund it. And I said, if you hire 1 person, you get 4 for the price of 1. That's a better deal than anybody else is giving you. And so he hired Suzanne, and she worked for us for a number of years and was paid by the College of Pharmacy. Lots of other people. A lot of medicine champions, the chief of medicine, the chief of surgery at the VA. Reuben Bressler was the chief of medicine at the university. Reuben Bressler would which he did, which I learned about serendipitously, is he hammered people that tried to prevent us from doing things. And because he told one doctor, just leave me alone, just let me do what I do. Because when Dave Hager left, Steve Goldman became the chief of cardiology, and Steve Goldman is a pretty grouchy guy, and I was terrified of Goldman, terrified. And so he told me he wanted to talk to me one day, and I walked in and he said, Jones, I want to know what makes you happy. And I looked at him and I said, I didn't think this was the conversation we were going to have here today. And he said, I think that what you do is great. I think what you do to teach the medical residents is beyond anything that we could hope for. And so I want you to stay here. I want to know what makes you happy. And I said, well, just keep doing what you're doing. I mean, just support us. That's what I need. And he did forever until he retired from the VA. Steve Thompson, Sammy Campbell, lots of folks, Tom Boyden, the 2 chiefs of GI that I worked with, Ian McGregor and Dick Samplinger, were incredibly supportive. And every time, if there was a problem, they were going to bat for us. And I think that's also a real plus. Bill Fisher walked by my office one day and he said, hey, you want a residency? And I said, sure. I had no idea what I was talking about, but I said, sure. And so he got us a residency. And the first residence, a guy named Nelson Nako, 1983. Nelson retired a little bit ago now. He was the pharmacy director at the hospital in Hilo, Hawaii. And great guy. And I still talk to him about how his family's doing. And over years, we grew from 1 resident to the next year 3, and then we continued to expand. And by the time I left, there were 8 residency positions. And now they've added a second-year residency in oncology. And over the years, I was the residency director for 112 residents, including Bob Lipsy. And, Bob didn't need to do a residency. Bob was very good when he started. He was one of those folks that came in at a really high level and I think left at a little bit higher level, but he really knew how to take care of patients and do his job well. And I always enjoyed, I'd go down on the wards and I'd ask Bob what he was doing. He goes, I'm stopping drugs. And I, what do you mean stopping drugs? He goes, well, no drugs, no levels. So that was Bob, which is true. I mean, if we didn't give him a drug that you needed to measure a level, our job got easier. And but he was very effective at doing that. The other thing that Bill Fisher did is he made sure that I met people. And over quite a number of years, we had about, 8 national VA pharmacy conferences. And I was at the first one in 1989 in a little town called Olive Branch, Mississippi, and you could actually go nowhere. So we were stuck in the building. for 5 days. And Bill Fisher made sure that I met every chief of pharmacy. And that network opportunity was very helpful over the years, because if I needed to talk to somebody that might have some expertise in something, I could pick the phone up and, talk to Marty Abramson in Boston, or talk to, Dick Rooney in Chicago, and not have to feel uncomfortable about it. And so networking is a critical issue, and you need to really pay attention to that. There was a conference in 1985 called the Hilton Head Conference that was about the future clinical pharmacy. It was done about 20 years after clinical pharmacy began. I look at myself as kind of a second generation clinical pharmacist. I wasn't the first wave, but I was taught mostly by physicians. And I can tell you the first generation was only taught by physicians because there wasn't anybody else. And people like Dr. Tong, was in that first wave, and at San Francisco General, part of get them to talk about the ninth floor project and learn some history, because it's an important thing. But they had regional conferences, and I got invited to the Western States Conference, where I also got to network with lots of folks. Max Ray, who's an incredible thinker in pharmacy, Bill Smith, who's been in a lot of different places, Long Beach Memorial Hospital, where he created a great place. Jerry Goyen, who was the dean at UC San Francisco, pulled me aside and he said, "You want a job at UC San Francisco? Because I kind of like what you say." And I thought, no, I don't want to go to San Francisco. But I got to meet those folks. Henry Manassi was a faculty member who became the ASHP executive vice president, and I got to know him. A couple of years later, they had a pharmaceutical care implementation conference that was outside of San Antonio, Texas, and I got to meet Linda Strand, who is one of the two authors of the definition of what is pharmaceutical care. And I spent a lot of time just sitting and talking to Linda, and I think we think alike, so we had a great relationship over quite a long period of time, thinking about how do we take care of patients, not how do we take care of drugs. Well, Bill Fisher left and went to Los Angeles, which was unfortunate for me. So we mucked around, and one of the guys, Joe McElroy, became my boss, which was an odd sort of a thing. And we worked through it. Joe's a good guy. And then Joe left, and we were kind of leaderless for a while. And I worked for the chief of dietetics, which was no fun. And I worked with a nurse, which was okay, but it wasn't fun because they really didn't understand pharmacy. And one day they announced that after the nurse had left, they announced that the new leader of what they called clinical care support was a guy named Doug Stevenson, who's a physician. And I thought, oh, how can this go right? Well, it turned out Stevenson was incredible. He was a young guy at the time, and he, good old boy from Texas, talked funny, talked kind of like this. But he said, "I believe in clinical pharmacy." He said, "I think you're the only people in the building that can make the care better and the cost lower at the same time. So nobody else can do that." And, I'd been there a long time by then, and I said, "Yeah, right, that'll never happen." Well, in about 2 years, we hired about 20 new clinical pharmacist positions because he convinced the hospital director that this was what needed to be done. And the hospital director told me when Stevenson left that he never thought that what Stevenson said we could do could be done. And he said, "You guys did more by far than he said could be done. I'm a believer." And so it became really easy for the people at the VA in Tucson in pharmacy to argue for new help because the hospital director actually got it and saw it. And I still think that that's an issue for many, many places. I then worked for a pharmacy chief that she and I didn't get along. And it really was hard to deal with. And this is another fork in the road moment. So I thought about retiring in 2006, and it literally, the way I describe it to people is I went through a year's worth of grieving because I didn't want to leave, because I loved the VA and I loved taking care of patients, but I couldn't deal with the bureaucracy that this person wanted me to deal with, and tried to make it as minimalistic as possible, that almost at every turn it was more bureaucratic. So one day I told her, I said, I'm done. July 2006, I can retire. And she says, what are you going to do? And I said, I have no idea, because I just made the decision about 10 seconds ago. And well, again, networking panned out, because one of my friends in the VA, his name is Tim Stroop, called me and he said, I don't want you to retire. I'm going to create a job for you. And so he created a job in the VA national office where I could work with every pharmacy residency program and help create those programs and do research and help people do research. So there's an academic detailing program in the VA, and I was heading up that toward the end of my time in the VA. And that's now very well established across the VA. And I worked with really cool people. Once again, they changed my boss. So Tim Stroop was no longer my boss. The person that came in didn't talk to me for 2 years. And one day he told me, actually it was at the APHA meeting, one day he told me, he said, I don't understand why I pay you. I said, well, Ken, it's not a shock, because you haven't talked to me in 2 years. I mean, I've told you I'll do anything you need to get done. That's my job. My job is to make you successful. But you've failed to talk to me. So it's not a surprise. And so they kept moving around the pieces. And finally I just said, I've had it. So in 2009, I retired from the VA. And I had no clue what I was going to do. So one of the things that I think for anybody that's young, you need to think about what you're going to do after you retire. Because retiring to nothing is a bad idea. And you don't want to do that. I did that. And it became an issue. Out of the blue, one of my former residents, Forrest Batts, called me and he said, hey, I'm at this new college of pharmacy, and we're thinking about starting a residency program. Would you be interested in being our consultant? And I said, sure. Where are you? He goes, University of Hawaii. So I talked to the department head, talked to the dean. We signed a contract. I got to go to Hawaii 4 times on their money. And we created a residency program, which actually turned out to be a residency program in a community pharmacy, not in a hospital. The hospital actually was the hospital where my first resident was the director of pharmacy. But they clearly weren't ready for that. They had a lot of really cool stuff they could have done, but they weren't ready. But we did create it in the community pharmacy, and it functioned for several years until that dean moved, and then the funding stream kind of dried up. John Palmer, who I mentioned earlier, he asked me to help teach in the College of Medicine. And so I met with the head of pharmacology, Glenn Sipes, and they said, yeah, we want you to work a little bit with us, about 10% of your time, And so I spent a lot of time doing case discussions with medical students and giving some lectures. I still give some lectures. I don't do the case discussions anymore, but I still do give some lectures. And I also, because I was bored, called up one of my VA friends that did research and said, what are you doing? And he said, well, I'm over here at the Center on Aging, and we're going to start a program. It's very much like what the VA calls home-based primary care, and we're going to do it in the university, and we need a pharmacist. And it's going to be 8 hours a week. We want you to do all this stuff. And my first comment to him is, well, you must not think pharmacists can do very much for 8 hours a week, but, that's fine. And so we started out, and that's what is Healthy Together Care Partnership. And it's grown over the last, whatever it is, 8 years or so. And so I now work 16 hours a week, and I probably work I don't know, 24 to 32 hours a week, but the paycheck's only 16 hours a week. Because there's a lot of stuff to do, and there are a lot of sick people that need help with their medications, and it really does matter that you're helping them. And then now what? Well, now what is I see the end. You know, I see that I'm an old guy, and so sometime probably this year I'm going to stop practice. I don't have a great rationale for why, but I see it happening. But I'm going to probably stay busy with working on the National Board, Residency Advisory Board for the VA. Try to do some consulting, maybe do some reflecting, to try to look at some things, do some traveling, since my kids are bi-coastal, one in Seattle and one in Boston. You know, that going back and forth, seeing them, going to university football and basketball, baseball games, probably high on my priority list. And some advice. So the one piece of advice that I would say to you is your future is not destiny. And I think a lot of times that gets to be kind of ingrained in people. You know, you're going to be exactly this. And you know, my career path was mostly serendipity. It was not something I sat down and said, boy, I know I'm going to do this and do this and do this. I never thought about the public health service. It was a great experience. I highly recommend being in a system. And I don't think most hospitals are systems. Most hospitals are standalone silos. But being in the public health service, you have an integrated system. Being in the VA, you have an integrated system. Being in the military, you have an integrated system. And you own the patient. And I think that's a really important issue. You know, one of the problems I think with healthcare today is insurance. They don't care if you're there or not. You know, if you're costing them a lot of money, they would really love you to pick up another insurance plan and not be on their roster next year because they save money. And but in the VA, in the Indian Health Service, you own the patient, whether they're in Tucson, Arizona, or Togus, Maine. You own the guy, and I think that is a much better system. It allows for a lot of networking that maybe not doesn't happen. My other piece of advice about practice is focus on patients. I get disappointed at people that follow guidelines without thinking very much about, do we really need to do this? One of the things that I learned from John Palmer decades ago is how much of a difference makes a difference. And I think there are a lot of things in guidelines that don't make much difference, but they become harder for patients to do. They become very costly. They become costly to society, not just necessarily to the patient, but to society. And everybody understands that healthcare costs are enormous. And some of that is because we do things that have little benefit to the patient. And Sir William Osler's quote is, care more for the patient than the specifics of his disease. And I would just change that to say, care more for the patient than the specifics of his drugs. And really make it about the patient and be their advocate, be trusted by them. And I've said it a couple of times, you want to find people you want to work with rather than people just to go to a job. I would tell you to be generous of your time and your treasure. Doesn't necessarily need to be to the university, although I'm sure Erica wants that. But the reality is there's a lot to be thankful for. And, you know, I support the Tucson Girls Chorus a great deal. I support the College of Pharmacy a great deal, the university a great deal. But the reality is there's a lot of things, and it doesn't necessarily need to be money. I mean, I've argued that we ought to have a small donor advocacy, go after a lot of little donors for a big accumulative amount of money. And eventually one of those guys is going to become a billionaire. And then That's Erica's job. Then she's going to go talk to that guy, that gal. But if you haven't been involved, I think it's harder for you to say, boy, I'm going to give you money, because now you've got a lot to give.
Bill, I'm going to have to interrupt here really quick. I know
Okay.
there's an exam at 1 o'clock, and so
Right.
I want to give a thank you so much for your presentation. Wow, just amazing. Your life and your career and what you've been able to share with our students. But I have a quick question, and well, let me just open it up. Does anybody have any questions that they would just like to go ahead and ask Bill directly? Go ahead.
So my current student's on here, so.
Yay.
Hi, Dr. Jones.
Hey, Anita.
I just put any words of wisdom, as I will be graduating this May.
Like I said, you want to find people that you want to work with. Try to be in a place that's innovative. Find a place where patients are the focus. I mean, I think that's a big issue, is you want to be in a place where you can take care of patients. I mean, you've seen that. You've seen that in the home visits we've done, right? I mean, the people we take care of are poor. They're very vulnerable. They are not necessarily people that understand the system. That's why I think Healthy Together is such a great model, because we piece together the pieces that other people don't. As you saw with the one we did a couple of weeks ago, the son, wants to take his mom to the emergency room at the drop of a hat. And, I personally have prevented that from happening a dozen times in 5 or 6 years. But that's what you really want. You really want to work with people that you want to work with, and not just it shouldn't just be a job. And that I think is an important piece. I personally believe every pharmacy student should do a pharmacy residency. I don't think that your clerkships are long enough. They're deep enough for you to be an expert. And now the bad news is the pharmacy profession hasn't made that opportunity available to enough people. That's not your fault. That's the fault of pharmacy. That's the fault of this profession, to not see that taking care of patients is what we should be doing. There's a lot of academic healthcare centers that do not have a pharmacy residency. That's sad.
Anybody else? Because I have one from the chat, and then Bill, one of our students had to leave for this exam, so if you don't mind, I'm going to send him your email, and he'd like to talk.
Absolutely, and anybody can have my email that they want to have, and we can, chit chat about whatever.
Yeah. So our last question was, what challenges did you experience in your career?
Challenges. Well, I mean, the biggest challenge is there's just so much to do, and the expectation of what pharmacists can do is pretty low on the part of physicians, and that's again why you want to be in a place where those expectations are not low. But if they give you all those expectations, it's really hard to meet them. When I've been around where they've discussed, we're going to build a program, and they talk about how many physicians they need and how many nurse practitioners they need, and then they say 1.0 pharmacists. I mean, I've actually said to people, that the Emancipation Proclamation was in 1865. You can't expect these people to be chained to a desk. They're going to take vacation. What do you expect them to do? And then if you expect them to do it, then you need to staff it the way that you expect it to be done. And they don't think like that. They don't think like that. It took me years to get the hospital director to actually understand there are things that we can do to make the care better. I mentioned Joe Rondoni. I mean, he runs his heart failure clinic at the VA in Prescott now as a volunteer. They've had nothing before. If he decides to quit, they'll probably have nothing after. I know from talking to him how many people he has managed and has kept out of the hospital. And until somebody says that keeping people out of the hospital has a value, then I think it's a hard sell. You know, I think if you want to be as we've talked about, you want to be in retail pharmacy, how are you going to manage the patient? You know from being in our conversations, you know that you don't know anything about the patient's medical history at the corner pharmacy. You don't even bother to talk to them for the most part. And you know, that's a problem. That's a problem. What I would tell you is what I tell every student that I've ever had this conversation with, is I expect you to be as good as me at the point in time that I need you. And if you're not, then maybe I shouldn't pay you. And you hear a lot of discussion about provider status. What I have never heard is, what are you going to do if you get it? And I think that's a problem. If you actually read the bill, it's about 5 pages long. It says almost nothing. What I see is people want to be paid. Henry Manasseh in 1987 said pharmacy is holding patients hostage because they're saying, until you pay me, I won't do anything. Well, the last time I looked, every pharmacist got a paycheck. So the question should be, why are you not doing something for the patient? Why are you not making it a better system? Why are you not connecting to the physicians? You know, one of the guys I worked with in the public health service went to a small town in Iowa, and he actually went and sat with docs and said, here's what I can do. That made a big difference in how his pharmacy functioned. It's not just dispensing a prescription. That's I worked where the Consolidated Mail Outpatient Pharmacy is. They fill 50,000 prescriptions in an 8-hour period with practically no pharmacists, maybe 8 people checking prescriptions. You can't do that workload. Part of the reason the VA can do what they do in the clinics is because 50,000 prescriptions are being done here and 6 other places across the country every day. Nobody can fill those prescriptions. So I think that's a vulnerability for everybody, is technology can fill the prescriptions. What are you going to do? And if society wakes up and says, why am I paying $125,000 a year if you never talk to me? I don't know how to use this drug. I mean, those are things that everybody needs to face. And you know, I don't know. I mean, but the challenges, I think, is there's so much to do and not enough people doing it.
Well, thank you so much. Our time is up, and I thank you all for being here. And I want you to know we have a little thank you gift. I don't know if you can see it, but if you don't have one of these, I can't see it. These cups, and when we meet, I'll give it to you. And these little mortar and pestles.
Okay, cool. I love it.
This is a thank you for taking your time and sharing your incredible career and your experience and the what you have given back to our students. We just thank you so much. My pleasure. This is being recorded. We will be putting this on our YouTube channel. Our next PharmCAT Chat will be April 22nd, and look in our PharmCAT Weekly for more details. Thank you again for participating, and we'll see you next month. Bye.
Thank you.
Bye-bye.
Bye. Bye.